We're going to begin the review of urology by reviewing some urologic emergencies. Let me talk a little bit about urological emergencies. Obviously, urologists may have to do emergently trauma work. And with the widespread use nowadays of medications for erectile dysfunction, they also have to take care on an emergency basis of patients that have priapism, erections that last longer than 4 hours. But traditionally, if you discount the trauma and you discount these new incidents of priapism, urologists have dealt with two classical emergencies over the years. And the first of those two is the first vignette that I'm going to read. A 14-year-old boy presents in the ER with very severe pain of sudden onset in his right testicle. There is no fever, pyuria, or history of recent months. The testis is swollen, exquisitely painful, high riding, and with a horizontal line. The cord is not tender. This is testicular torsion. And testicular torsion is one of those two classic urological emergencies. Now you have all of the findings here. The right age group, the absence of fever, pyuria, the fact that the testicle is in a position that is abnormal, it's high riding and horizontally located, and the cord is not tender. And given this complete presentation, what a urologist will do in this country is rush this youngster to the operating room to save that testicle, untwist the cord, do an orchiopexy, and follow typically with an orchiopexy to the other side so the other testicle is not at risk. And that urologist who does this would not have wasted any time doing diagnostic studies, because there is urgency to the management in this case. The diagnostic study, by the way, had it been needed, had not the case been clear, would have been a sonogram, more specifically a color flow Doppler ultrasound, the kind of sonogram that shows you if there is blood flow to the organ or not. But again, the emphasis is if it's clear-cut, if it's clinically very, very classical like this one, the best answer is immediate surgical detorsion. One of the reasons that I'm mentioning the role of the sonogram in the diagnosis is because testicular torsion could be confused with another clinical entity that is very similar in its presentation. Let me read you that one, vignette 2. A 24-year-old man presents in the emergency room with very severe pain of recent onset in his right scrotal contents. There is fever of 103 and pyuria. The testis is in the normal position and it appears to be swollen and exquisitely painful. The cord is also very tender. This is acute epididymitis. You can see then that both acute epididymitis and testicular torsion present with very severe pain in the scrotal contents. And both, of course, are young males that, could be prey to either one of the two. But if you look at the details, there are differences. The acute epididymitis is something that is acquired by sexual transmission. So the patient with the acute epididymitis is typically a little older than the patient with testicular torsion. Then there is the fever and the pyuria. There is the fact that the cord is tender. And there is the normal location of the testicle. And so in reality, when you look at the details, you should be able to recognize on the exam, this one is acute epididymitis. The previous one was testicular torsion. And acute epididymitis is treated with antibiotics. However, and this is important because you might find that answer on the exam, there is such a fear of a potential medical legal implications of missing the diagnosis of testicular torsion that frequently in this country when a urologist sees a patient with acute epididymitis, they order a sonogram, the color flow Doppler ultrasound that I was talking about, to be absolutely sure that a testicular torsion is not being missed. Okay. Now we move to the second of those classical urological emergencies. I'm going to use an illustration for it, of a particular case, and then I'm going to generalize a bit more because we see these in other circumstances than the one that I'm about to read. We're now on vignette number 3. A 72-year-old man is being observed with a urethral stone that is expected to pass spontaneously. He then develops chills, a temperature spike to 104, and flank pain. Let me analyze this. It is perfectly appropriate to let a patient with a small urethral stone who's already way down at the end of the ureter, almost ready to get into the bladder, it's perfectly acceptable to let that stone pass. And so patients like these, we see them all the time. They are given plenty of fluids, medication for pain, because we know the little stone is about to fall into the bladder and be no problem anymore. But if we have the misfortune that an infection supervenes in that patient, then we're going to have a deadly combination: obstruction plus infection. Because obviously that side of the urinary tract that has that stone in the ureter waiting to pass is obstructed. If an infection then supervenes, we get that second urological emergency, namely the combination of obstruction and infection. Let me say this again in a different way. Having obstruction of the urinary tract alone is bad. Having infection of the urinary tract alone is bad. Having the two together is horrible. Renal function could be lost in a few hours. Death could in fact occur. And so the urologist who's taking care of his patient, when that urologist gets a phone call that says, you know what, your patient that was passing the stone just had a chill and a fever of 105, that urologist will rush to the hospital to do something about the obstruction. And in fact, he'll be a little late to do the big invasive things to retrieve the stone or to shatter the stone. Probably a nephrostomy tube will be put above, because it's essential that that obstruction be relieved as quickly as possible, in addition, obviously, to antibiotic therapy. Now, let me continue then on this theme, because now that we understand that obstruction and infection happening together are very, very bad, from this follows that in the management of urinary tract infections, if the infection is very bad, or the infection is happening to somebody who shouldn't have an infection, we feel compelled to do urological workup to make sure that there isn't obstruction, because we know that the combination of obstruction and infection is much worse than either of them alone. Let me exemplify that now with some vignettes that continue. An adult woman relates that 5 days ago she began to notice frequent, painful urination with small volumes of cloudy and malodorous urine. For the first 3 days she had no fever. Let me stop there and analyze what we have read so far. Because an infection of the urine in an adult woman of reproductive age is not an unusual infection. Women who are sexually active can very easily get bladder infections because their urethra is very small and it's not too difficult for the bacteria to move up. And so, if all we had on our exam question was what we read so far, the answer would be appropriate antibiotic therapy. We begin typically with empiric therapy, and if necessary, adjust with urinary cultures. But now let's keep reading. But for the past 2 days, she has been having chills, high fever, nausea, and vomiting. Also in the past 2 days, she has had pain in the right flank. She has had no treatment whatsoever up to this time. Now what we're talking about is pyelonephritis. And pyelonephritis is not a common, ordinary infection about which we do not get very concerned. Pyelonephritis is bad. This lady now needs to be hospitalized. This lady needs intravenous antibiotics. This lady needs urinary cultures. But this lady also needs a urological workup. We also want to be sure that the reason for the infection to be worse than might have been is not obstruction. And probably the best test to do that, because it is completely non-invasive, very easily done, available everywhere, and very good to detect obstruction of the urinary tract, would be a sonogram. So your best answer for this vignette, once you've read the whole vignette, would be hospitalization, intravenous antibiotics, urinary culture, and the sonogram. Let's continue on this same theme. We're now on vignette number 5. A 62-year-old man presents with chills, fever, dysuria, urinary frequency, diffuse low back pain, and an exquisitely tender prostate on rectal exam. This is acute bacterial prostatitis. Well, the same way that bladder infections are common in young sexually active women, acute bacterial prostatitis is common in old men. And so we would not say at this point, "Ooh, what an strange, unusual infection. Why is that happening to this man?" We know this happens. We treat it with antibiotics, and I might add a very important detail. That rectal exam that was done to verify the diagnosis should not be repeated. Because every time you keep mashing in that prostate, you're sending bacteria into the blood. So you have your diagnosis, you now treat it with antibiotics, and no fancy workup is needed. But let's contrast that situation with the next vignette. A 33-year-old man has urgency, frequency, and burning pain with urination. The urine is cloudy and malodorous. He has mild fever. On physical examination, the prostate is not warm, boggy, or tender. You know, the people who get prostatitis are typically older than this gentleman at 33, but we wanted to check for that because that would be the simplest explanation for the symptoms this patient has. Once we realize there is no prostatic inflammation, then we have to ask ourselves, what in the world is a 33-year-old male doing with a urinary tract infection? Because that is not common. That is unusual. And so it would not be appropriate to simply say, well, treat him with antibiotics and that's it. We have to make sure that the reason for this unusual situation is not obstruction of the urinary tract. So yes, he needs the antibiotics, he needs a urinary culture. He also needs a sonogram as a good way to begin a urological workup. Let's repeat this theme. We're going to cut away from my face and go to words on the screen. So if we have a question on the exam where a urinary tract infection is described, the strategy that I'm suggesting for you is ask yourself, is this type of infection common or not? If it is common, it would be bladder infection in a young woman or prostate in the old men, and you can just treat them. But on the other hand, if the infection is more severe than it should be, or is happening to the wrong kind of patient, then in addition to treatment, you need a urologic workup. And a very good way to begin would be to begin with a sonogram. All right, this is the end of our urological emergencies.